بسم الله الرحمن الرحيم. بإشراف مباشر من السيد رئيس جامعة تكريت الأستاذ الدكتور جهاد دياب محل المحترم، ومتابعة من قبل السيدة عميدة كلية طب الاسنان الأستاذ مساعد دكتور بان اسماعيل الصديق، وأيضا بدعم من أكاديمية شبكات سيسكو العالمية في جامعة تكريت، وبالتعاون مع فريق منصة جامعة تكريت التعليم الالكتروني. تستقيم إن شاء الله المدرس المساعد سهى أسود دهش، اختصاص في ماجستير في أمراض وجراحة ما حول الأسنان، والتدريسية في كلية طب الأسنان في جامعة تكريت. محاضرتها بعنوان Gummy Smile Diagnosis and Treatment. على بركة الله. تفضلي دكتورة.
السلام عليكم ورحمة الله وبركاته. نشكر الدكتور مهند على هذا التقديم، وبداية أنا أحب أشكر القائمين على هذه الندوة والمنظمين وأعضاء اللجنة المركزية للدعم الفني، وأرحب بكل الحضور وأتمنى لكم إن شاء الله السلامة والصحة للجميع. My lecture's title is Gummy Smile Diagnosis and Treatment. In this lecture, we will understand what's the meaning of gummy smile, what are the elements of an aesthetic smile, what are the causes of the gummy smile, and how could we diagnose cases with gummy smile, and what are the treatment options. By definition, gummy smile means excessive gingival display during smiling, or the display of 4 mm or more of the gingiva during smiling, which is considered as unattractive. This condition is more common in females than in males. As a dentist in our clinics, we have seen many cases of gummy smile. These cases, in most of them, the gummy smile causes a significant aesthetic problem that they seek a treatment for. Many of them tend to cover their mouth during smiling just to hide the gummy smile. So it's important for the dentist to understand what are the causes behind this condition and what are the treatment options that are available. First of all, you should understand what are the elements of an aesthetic smile. For a smile to be considered as an aesthetic, all maxillary teeth should appear during smiling, with 0 to 2 millimeters of the gingiva, which means that no more than 2 millimeters of the gingiva should appear during smiling. This line, or the inferior border of the upper lip, is called the smile line. And according to the level of the smile line, we have 3 types of the smile. The first type, and the most common one, is the average smile type, in which 75% to 100% of the clinical crowns of the maxillary anteriors appear during smiling. The second type is the low smile type, in which less than 75% of the clinical crowns appear during smiling. The third type is the high smile type, in which all the maxillary anterior teeth appear during smiling, along with a continuous band of the gingiva. This continuous band of the gingiva, if it is within 2 millimeters or less, it is acceptable. However, excess gingival display that exceeds 2 millimeters reduces the attractiveness of the smile. And if it exceeds 3 to 4 millimeters, it is considered as an unattractive gummy smile. An important point to take into consideration during the diagnosis of gummy smile cases is the rest position. During the normal rest position, the lips are slightly apart from each other, and the amount of incisal display is 3 to 4 millimeters. So again, the lips are slightly apart at rest position, and the amount of central incisors that show during rest position should not exceed 3 to 4 millimeters. Keep this point in your mind because this will help us in diagnosis later on. The amount of incisal display at rest position is influenced by the gender because it is less in males than females and also decreases with age. When we talk about the causes of gummy smile, we should take into consideration all the components of the smile, including the jawbone, the lips, the teeth, and the gums. Because the cause of the gummy smile may be vertical maxillary excess or increased growth of the maxilla or the upper jaw in vertical dimension. Or it may be over eruption or protrusion of maxillary incisor. Also, short upper lips and hypermobile upper lips may be causes for the gummy smile. And the last cause is the altered passive eruption of the gingiva. So each of these causes may be responsible for the excessive appearance of the gums during smiling. Let's take them one by one. In cases with vertical maxillary excess, there is an increased growth of maxilla in vertical dimension. These cases present clinically with incompetent lips and increased incisal display, more than 3 to 4 millimeters. Also, when you check the clinical facial height clinically, there will be increase in the lower facial height compared to the upper facial height. These cases can be confirmed by cephalometric analysis. Cephalometric analysis is a type of radiograph on which certain points are placed to make certain measures which help us in diagnosing skeletal malocclusions. In cases of vertical maxillary excess, we will have increased lower facial height. This is the red line here indicates the lower facial height. Normally, this height on cephalometric analysis should be 55%. In cases with vertical maxillary excess, this height will be more than 55%. Another measurement is the dimension or the distance from the inferior or the anterior nasal spine and the incisal edge of maxillary incisor. This dimension normally should be 1/3 of the lower facial height, but in cases with vertical maxillary excess, this will be greater than 1/3. So this analysis helps us in diagnosing these cases. So whenever you have a gummy smile patient, you should look at him or her at rest position. If the patient has excessive gingival display during smiling and excessive incisal display greater than 3 to 4 millimeters at rest position with incompetent lips at rest position, you should suspect vertical maxillary excess as one of the possible causes. The next cause for the gummy smile is the over-eruption or protrusion of maxillary incisors. Here the problem is dentoalveolar and not skeletal. The problem in the teeth. These patients also present clinically with excessive incisal display and incompetent lips at rest position. But you can differentiate them from the previous cases of vertical maxillary excess by the presence of incisor protrusion. The incisors are protruded and reduced facial height with deep bite. And the gummy smile in these cases is only in the anterior area. The third cause for the gummy smile is the short upper lip. The average length of the upper lip from the inferior border of the nose to the inferior border of the upper lip is 22 to 24 millimeters in male and 20 to 22 millimeters in female. Also, the central portion normally should equal to the lateral portions of the upper lip, while in cases of short upper lip, the central portion will be shorter than the lateral portions. Cases with short upper lip also presents with incompetent lips and increased amount of incisal display greater than 3 to 4 millimeters during rest position. So in all cases, you should look at the patient at rest position. When you have incompetent lips and increased amount of incisal display at rest position, you should suspect one of these three cases or causes, which are the vertical maxillary excess, protrusion of maxillary incisors, or short upper lips. Because the next two causes will not cause incompetent lips or excessive incisal display at rest position. Here is another photo of a patient with short upper lip. You can notice the incompetent lips and the excessive incisal display at rest position and gummy smile during smiling. Also, another feature is that the short central portion of the short lip or short upper lip causes an inverted smile line. Look at the smile line here, which is the inferior border of the upper lip. It looks like an inverted line, which helps us also in the diagnosis of short upper lip cases. The fourth cause of the gummy smile is the hypermobile upper lip. In this case, the jaw is normal, the teeth are normal, the gingiva is normal, but the problem is with the hyperfunction of the elevator muscles of the upper lip, which causes extreme elevation of the upper lip during smiling. The average of elevation of the upper lip on smile from the rest position until maximum smiling is 7 to 8 millimeters, while in cases of hypermobile lip or upper lip, the apical movement of the upper lip from the rest to maximum smile will be greater than 9 to 10 millimeters. Here's another case of hypermobile upper lip. The fifth and the last cause of the gummy smile causes is the altered or delayed passive eruption, which means delayed migration of the gingival margin in an apical direction after the completion of active eruption. Tooth eruption passes through two phases, the active eruption and the passive eruption. The active eruption, the tooth moves in occlusal direction from the site of development to the site of function until it reaches the opposing tooth. And once the tooth reaches the opposing tooth and the functional position, the gingiva starts to move in an apical direction until it reaches another position, which is 1 millimeter coronal to the cemento-enamel junction. This is called passive eruption. Failure of the gingiva to migrate in apical direction will result in a condition called altered passive eruption, in which the clinical crowns of teeth appear short because of the greater coverage of the clinical crowns with gingival tissues. So, these cases are relatively easy to diagnose because the clinical crowns appear short and the proportions of the teeth are dysregulated. Ideally, the proportions of the central incisor as follows. The width of the central incisor should be 80% of the height, which means that if we have a central incisor with an 8 millimeter width, if the width is 8 millimeter, then ideally the length of the tooth should be 10 millimeter. These proportions can be measured and determined using periodontal probe, or more simply using this tool, which is called choose proportion gauge or T-bar. This tool composed of vertical arm and horizontal arm, and here is the incisal stop, and you can see the color-coded bands. Simply, if the mediodistal dimension of the tooth is lockets between these blue bands, then ideally the gingival margin should look at also at the blue band on the vertical arm. Likewise, if the mesodistal dimension, as you can see here in this tooth, the mesodistal dimensions of the tooth or the width is located between the red bands. So ideally, the gingival margin should look at the red band on the vertical arm. So this tooth has an ideal proportions. But if you look at these teeth on the right of the screen, you can see that the proportions are not ideal. So using this gauge, we can measure the proportions and determine where exactly the gingival margin should be. And this helps us to determine the amount of tissue that need to be cut. Short clinical crowns can be caused by other causes other than delayed passive eruption, such as attrition of teeth and gingival enlargement. Gingival enlargement, in which the enlarged gingiva may cover the clinical crowns, causes unaesthetic appearance and also gummy smile. This gingival enlargement may be caused by gingival inflammation or the use of certain medications, such as anti-epileptic drugs. Differential diagnosis. As I mentioned previously, gummy smile is a descriptive term and it is not caused by a single cause. There are many causes that may be responsible for the excessive gingival display during smiling. So it's important to be able to differentiate these causes, because when planning a treatment for a gummy smile, the key is to diagnose the reason for the excessive gingival display, because each reason requires a different treatment plan. The first step in diagnosis is the assessment of upper lip relative to the incisal edge of the maxillary incisors at rest. As I mentioned previously, the first step is to look at the patient at rest position. The normal incisor display at rest position is 3 to 4 millimeter. If there is excessive incisal display or incisal display greater than 3 to 4 millimeters at rest position, you should suspect one of these three causes: short upper lip, vertical maxillary excess, maxillary protrusion. And then you can confirm these causes by other factors, such as measuring the upper lip in cases of short upper lip, and taking cephalometric analysis and assessing the lower facial height in cases of vertical maxillary excess, and examining the teeth and the lower facial height in cases of protrusion of maxillary incisors. In all these cases, there is incompetent lips and increased amount of incisor display at rest. If the amount of incisal display is within normal limits, but there is gummy smile, then we should suspect either hypermobile upper lips or altered passive eruption. In cases of altered passive eruption, always the proportions of the teeth are not in ideal proportions, while in cases of hypermobile upper lip, in most cases, the teeth are normal and the proportions are ideal. Treatment options. Before proceeding to treatment options, we should keep in mind that in each particular case, the gummy smile may be caused by single cause or by a combination of more than single cause of the mentioned causes. So you should mention or you should identify all the causes and then proceed to the treatment plan. Cases with vertical maxillary excess, ideally treated with growth modification using headgear and occlusal splint in cases that still in growth period, usually at the age of 8 to 10 years. After the end of growth period, cases with vertical maxillary excess can be treated using orthodontic treatment or surgical maxillary impaction, depending on the severity of the case. Here you can see the procedure of the vertical or surgical maxillary impaction, in which a part of the maxilla is surgically cut in a procedure that is called surgical maxillary impaction or Lefort 1 osteotomy. And this procedure gives a very stable results and a reduction of the gummy smile by about 6 to 8 millimeters. However, vertical maxillary excess cases that refuse to undergo surgery can be treated by Botox injections as an alternative. But Botox injection gives a transient and temporary results and need to be repeated each 6 months. In this slide, you can see the results of the surgical maxillary impaction procedure. You can see the before and after photos. Is it clear? You can see the difference in the smile before and after surgery. Huge difference. Cases with over-eruption or protrusion of maxillary incisors should be treated by orthodontic treatment for intrusion of upper incisors. So, when you have a case or a gummy smile case and you perform your diagnosis and notice that the cause is the protrusion or over-eruption of maxillary incisor, you should refer the case to an orthodontist. This case should not be treated by Botox or fillers or any other treatment option. They should be referred to an orthodontist for orthodontic treatment, which will solve their gummy smile problem. Cases with hypermobility of upper lip or hypermobile upper lip can be treated by using Botox injections and lip repositioning surgery. And it's better to treat them with both of these procedures. Botox or botulinum toxin is a neurotoxic protein that is synthesized by gram-positive anaerobic bacteria, Clostridium botulinum. It inhibits the release of acetylcholine, the neurotransmitter at the neuromuscular junction, which prevents the muscle contraction. So, in cases of gummy smile, diagnosed with hypermobile upper lips, we can use Botox injections at certain points to relax the muscles or the elevator muscles of the upper lip so that the patient can smile but without extreme elevation of the upper lip. As I mentioned before, Botox is a transient therapy or temporary therapy. It should be repeated every 3 to 6 months. Lip repositioning surgery is a surgical procedure accomplished by removing a strip of the mucosa, as you see here. We made 2 incisions, 2 partial thickness incisions, one along the mucogingival junction from the molar, from the first molar on one side to the first molar on the other side. And the next incision is 10 to 12 millimeters apart from the first incision. And then with the blade, we remove this strip of tissue and then suture these 2 edges together. This results in reducing the height of the vestibule and limiting the action or restricting the muscle pull. I have to mention that this procedure have a high tendency to relapse, and the patient will have a gummy smile again within 6 months to 1 year. So it is better not to perform this procedure alone. It should be performed with Botox. Cases with short upper lip are treated by lip repositioning surgery and also fillers. The filler aims to increase the volume of the lip to minimize the gummy smile. In cases with altered passive eruption, in which the gingiva covers more of the clinical crowns, and the clinical crowns appear short and the proportions of the teeth are not ideal. In these cases, we should perform aesthetic crown lengthening. Aesthetic crown lengthening means increasing the length of the crown by performing gingivectomy or gingivectomy plus resective surgery plus bone removal. To decide whether you need gingivectomy only or gingivectomy plus resective surgery, this mainly depends on respecting the biologic width. The biologic width, as you can see here, is the distance between the deepest point of the gingival sulcus and the crest of the alveolar bone. It consists of epithelial 1 mm epithelial attachment and 1 mm on average connective tissue attachment. So the total biologic width is about 2 mm. It's important to maintain this biologic width and not to violate this width by any procedure, because this biologic width and this attachment act as a barrier that prevents bacterial invasion. So, choose gingivectomy when the amount of tissue that you need to cut will not invade the biologic width, and choose gingivectomy plus bone cut when the amount of the tissue that you need to cut will invade the biologic width. So again, if the amount of tissue that we need to cut to expose the clinical crown of the tooth will not invade the clinical or the biologic width, we should go for gingivectomy alone, without bone removal. If the amount of tissue to be cut to increase the length of the clinical crown will invade the biologic width, in this case, we have to reflect, we have to do gingivectomy and then reflect our flap, remove some bone to provide space for the biologic width, and then suture our flap again. To know whether the amount of tissue that you need to cut will invade the biologic width or not, simply you should follow the steps of the aesthetic crown lengthening. The correct steps are as follows. First, you should determine the amount of tissue to cut. And this can be determined by measuring the tooth proportion using the periodontal probe or the true proportion gauge, as we mentioned previously. For example, here in the picture below, if the width is 8 mm, then ideally the height of the tooth should be 10 mm. If we have a height of 8 mm, then we should cut 2 mm of the gingiva in order to get the ideal proportion. After determining the amount of tissue to be cut, the next step is to determine the distance from the gingival margin to alveolar bone. This procedure should be performed under local anesthesia because it is painful. After anesthetizing the patient, you insert the periodontal probe in the sulcus at an angle until you touch the crest of the alveolar bone, and you take the measurement, this measurement. Now you have two values, the bone sounding value and the amount of tissue to be cut. The next step is to subtract these two values, bone sounding value minus the amount of tissue that needs to cut. If this value is less than or greater than 3 mm, you can do gingivectomy alone because 3 mm is sufficient for biologic width. If the value is less than 3 mm, then you should do gingivectomy plus bone cut to provide adequate space for the biologic width. I hope that this point is clear for you. And here we can see a case of altered or delayed passive eruption before and after treatment by aesthetic crown lengthening. So when you have a case like this in your clinic, you should determine the cause because this case doesn't require treatment by Botox or filler or any other treatment. It just needs to lengthen the clinical crowns because you notice that the proportion of the teeth are not ideal. So after treatment, we get the ideal proportion and also we eliminate the gummy smile. At the end of my lecture, as a summary, we know that gummy smile may cause a significant aesthetic problem for the patient. Gummy smile does not caused by a single cause. It may result from different causes such as hypermobility of upper lip, short upper lip, vertical maxillary clip, protrusion of maxillary incisors, altered passive eruption. Each of these causes require a specific or a different treatment option. And you can see here that we have many treatment options such as Botox injections, lip repositioning surgeries, fillers, growth modifications, orthodontic treatments. So, to avoid confusion, you should follow the correct protocol in the diagnosis. And once you reach the correct diagnosis and you identify the cause, then you can proceed for treatment planning. So, my advice is don't rush to treatment. Don't rush to treatment. Take your time to reach the correct diagnosis, to identify the causes, because identifying the causes is the key for selecting the correct treatment option. Thank you for kind listening, and I hope this lecture was beneficial for you.
نشكر دكتورة سهى على هذه المحاضرة القيمة حقيقة والممتعة، وننتقل إلى السادة الحضور إذا كان عندهم أي أسئلة. احنا راح نفتح المايكات. الشخص اللي ما عنده سؤال أرجو أنه يعني يغلق المايك.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
شلونك دكتورة سهى؟ هذه دكتورة ربان.
هلا دكتورة.
هلا حياتي دكتورة. دكتورة بس سؤال، البوتوكس من يعني النقاط اللي نضرب بيها، يعني ايش قد الكمية؟ ايش قد نحط كمية؟ كل ضربة ايش قد؟
دكتورة هذه طبعا بها يعني تفاصيل أكثر، يعني أنا بس انطيت ملاحظة لأنه هي كل بوينت لازم بدبث معين ويعني وكمية معينة من البوتوكس. وهذه يعني أنا ما عندي سلايد حاليا إنه حتى أشرح لك عليها، بس مثلا فور إكزامبل خلينا نرجع على سلايد البوتوكس. here. شوفي السلايد دكتورة؟
شوي يعني يمكن لو تكبري لحظة بس. اي عم اشوفها. اي
هذا أكثر نقطة تكون ديب. هنا أنا طبعا بالسلايد مذكورة اليونتس، يعني كم يونت من البوتوكس نعطي، بس بشكل عام يعني اللي مكتوب عليها 2 يونتس تكون superficial. تكون يعني النيدل تكون superficial، يعني تدخليها مجرد مليمتر أو مليمترين. أوكي؟ بس هنا أنا فوق تشوفين هاي النقطة، أعلى نقطة هنا هذا corner of the nose هنا تكون deep، يعني تكون 4 to 6 مليمتر. دخلين النيدل تقريبا كلها، هاي النيدل مال الأنسولين كلها تدخل. وانجكت 4 units.
4 units لأن مدى الظفر عندي
ما واضحة؟
لا يعني قصدي الرقم ما أشوفه، أنا شوي عيني
بالضبط. فوق الديب، المنطقة اللي نحقن بها ديب اللي هي أعلى نقطة هاي اللي نشوفها على التو سايدز، هذه ندخل النيدل كلها تقريبا 4 إلى 6 مليمتر وننطي 4 units.
نعم.
بقية النقاط تكون superficial وتكون 2 units.
نعم. شكرا جزيلا دكتورة.
أي أحد من السادة الحضور عنده سؤال للدكتورة سهى؟
نعم دكتور مهند، أكو أحد؟
أنا فتحت المايك، ما أعتقد أكو أحد من السادة الحضور. سادة الحضور، ما أكو أسئلة للدكتورة سهى؟ دكتورة سمعيني؟ ما أكو أحد من الحضور.
نعم
يعني
أسمعك.
أعتقد بس كانت دكتورة بان.
تمام.
فإذا ما عندش ملاحظات احنا هنا ننهي المحاضرة.
أشكركم وأشكر جهودكم طبعا ووقتكم اللي انطيتوه لنا وتحتوا لنا هاي الفرصة. شكرا جزيلا.
نشكر دكتورة سهى على هذه المحاضرة القيمة، ونشكر الحضور الكرام على تواجدهم ومشاركتهم ويانا، وإن شاء الله نكون على ندوات ومحاضرات إن شاء الله قادمة. وبالنهاية تحياتنا للجميع، والسلام عليكم ورحمة الله وبركاته.